Christmas, everybody. And happy Hanukkah, Kwanzaa, whatever the hell you're celebrating. Whatever holiday you're enjoying, enjoy it. As you can see, I'm all decorated out here. Santa over here in the skull, he's dead. Christmas is canceled. Go back to bed, kids. So welcome back to Lary Talk. I am your host with no throat. I am Henry King. This week's episode is going to be about radiation. And before we get into all that, I wanted to say thank you guys for the support on last episode with the interview with Cindy Davis. It was the quickest watched episode that has been uploaded so far. It doesn't have a lot of views on YouTube. It's got like 80 something. But considering that nobody really gives a crap about this, and I'm not really like, out there doing entertainment things, it's pretty impressive. So also, I'd like to give a shout out. I bought a shirt. I'll show you the pictures, and got a couple made for some friends and for Aaron. So show you it real quick here too. I got pictures. Fits nicely. So shout out to Shirt Ninja at the local store here. I wanted to get a shirt made for the show, debating if I want to sell them, try to support the channel, that kind of thing, because it does cost money, believe it or not. And I was looking online for places, and everybody wanted so much money and everything. And then I found a local place here in Ithaca. So go check them out. They do custom shirts. They have a bunch of funny ones of their own. They got a total website. You can check it out right there. And let them know we sent you. Not a sponsor, by the way. I'm just giving them a nice little shout out because they hooked me up. And as always, we're going to do the silent partner bit with the book. I was watching a preview episode, and it kind of funny that in that episode, I'm like, I'm never going to sell you a book. And then every episode, I'm like, buy the book. But even though it's not for sale, I'm just saying, get the book, you know what I mean? So I find that kind of funny, but it's worth it. It's a good book. It's called The Silent Partner, My First Year, and it's a laryngectomy. Aaron Wayne's take on his first year becoming a laryngectomy. It's funny. It's a good read. It's not filled with a lot of scientific mambo jumbo. And I suggest you check it out. And he might even send you some stickers that you can decorate your HME with. Now, mind you, guys, you don't have to be a Larry to get this. If you're just curious, call him up, man. I'll have his email there, like always. And let's get on with this episode, right? So, quick disclaimer. This will be my third time recording this. I'm not very smart, man, Jenny. The way I have everything hooked up, I only got one USB port that's good. And I got an adapter to it. And it's got some buttons onto it. And somehow I had my mic turned off, the one right here. And it's a bad way to find out that your computer laptop mic is horrendous. So I did an interview this week with Dr. Powell. He's a radiation oncologist. And sadly, my sound is horrible. His is good, but mine is bad. And I apologize for that. I didn't even notice it. Like didn't notice it until it was too late. And then I had to re-record it thinking, well, maybe it was just a connection or something. No, it's just me being stupid. So third time's a charm. Here we are. So in this episode, we're going to go over my radiation experience, and then we're going to have a little chat with Dr. Powell. This is going to be a long episode, so buckle up, all right? Dr. Powell has a lot of information, and he spewed it out at us, and I thank him for it. So let's get started, right? So you're going to do radiation if your doctors, what your team decides. A lot of people end up doing radiation and chemo together. Some end up just doing radiation. Some do it before surgery, some do it after surgery. It all depends on you. And remember, everybody's different. And I like to also remind everybody that I got lucky on mine, so I handled mine a little bit better than what most people would. Radiation, what is it, right? Well, you're pretty much getting radiation. It's exactly what it is. It's radiation, X-wave radiation. We'll get into that part of it later in the interview. You're pretty much you're going to get an MRI before you go do this, right? And the MRI is going to show them where the actual cancer is. So that way they can shape it to the tumor or the cancer. And so that way they're not overshooting everything, because the radiation, it's coming in no matter what. The only thing that's going to block that coming in is lead. And then it's up to like a certain amount, blah, blah, blah. The radiation, as soon as you hear it, you freak out. Everybody thinks, lost hair, just like chemo, lost the hair and everything else. And it's true, but it's only where the radiation beam is actually hitting you. Now, as I said, I had recorded this damn thing 3 times now. I did have grown out. I had my facial hair grown out so that I could show you what damage it does with your hair. But I'll have to show a picture here of me with a beard last year because, Anyway, what it did with me with the side effects on it anyway is I had a perfect line all the way around my head from where the radiation blasted. So it made shaving a lot easier because anything below that jawline was gone. It was done for. And it's slowly coming back. Like the hair up here kept growing normal, but the hair down here where the radiation was slow to come back. And it was like almost going through puberty again with the peach fuzz and all that stuff. And sadly, now it's growing in gray. Downside of that one, right? Stress or whatever. But it's not just front, okay? So it goes all the way around your head because what they do is they lay you on a table, right? And then the beam goes around you. You know what I mean? Unlike an MRI, you don't go inside a machine. The machine goes around you. Okay, so you're going to go like 10 minutes going one way, and then the machine stops, and it's like, 10 minutes the other way, maybe 7 minutes each way. But either way, it's going to go one way and then the other way. And it's a perfect circle. They're going to line you up with lasers and stuff like that. Well, let me go back into it a little bit. When you go into it, you're going to get measured for a mask. And this is the thing everybody hates. Anybody that's ever gone through this, they hate this mask. This is a mask they use for head and neck cancer. What it is it's a plastic fiber. They warm it up and then they shape it to your face. When it's first brought to you, it's a flat surface. They mold it over your face and then attach it to the table. And the reason why they do that is so that your head is in a perfect alignment every time, because they don't want to blast what don't need to be blasted. So this thing, a lot of people hate it. A lot of people. I will have at the end of the episode a couple pictures and stuff like that. Actually, Aaron Wayne had sent me most of them of what people did with their masks after radiation. A lot of people like destroyed them, burned them, had this huge festive thing going on. I figured I'd keep mine. I was going to use it for the garden, but now I'll just keep it for like educational purposes or something like that. But everybody bitched about the mask. I didn't really mind it too bad. And when I say attached to the table, it's not like you're bolted down, you couldn't get up if it was an emergency. I mean, it's just snapped in. It's nothing major. So they will also, when you go in there and measure for the mask, they'll give you a little tattoo, a little dot. You can see it right there if you're watching on a video. Right in the middle of the chest. They lined you up with laser beams, okay? So that way it's always accurate. You know what I mean? Obviously, straight angle, can't mess it up. So that is so they can line you up and mark it and all that good stuff. So again, you're always getting the same spot at all times. So like this, I think the tattoo part of it's probably the worst part of it. And I mean, honestly, who wants a dot? Now, if you turn it into something, cover it up, fine, whatever. But in my luck, as soon as I got it covered up, I need it again, So I haven't done anything with it. As far as while the radiation is going, the machine isn't really all that loud. I mean, it makes noise, but it's not too bad. And you don't feel anything while it's happening. At least I didn't. I don't know. Some people claim they have. I don't know. It's such a fucking. It's not like you're getting like this huge beam of heat, but it's not nothing. You don't feel anything. Your side effects don't even start in until like a week later, usually. You know, a couple of weeks later. Sometimes some people it might be a little different. A couple of days later, but you're getting a small dose of radiation every day over a course of 5 to 7 weeks. So, you know, think about it. I mean, everybody compares it, even though it's nothing like sunburn, but everybody compares it to like a sunburn. You go out in the sun, you get burnt. Okay. You go back out there and get burnt in the same spot. It gets worse. So on, so on, so on. It's the same principle, you know. As far as like the lasting side effect from it for me was like I said, the hair thing. And I had this red line, slight red line. Looks like I got a sunburn, which I don't mind. I guess it makes me a real redneck, you know. But hell of a way to get it. But yeah, whatever, man. I went on a truck, so good. And the other side effects, you know, like it could cause swelling. It made it so I couldn't swallow. Bad inflammation, you know. I mean, that's how it works. So I had a bag tube. I had a bag tube too. I had a bag tube that was way too long, mind you. Whoever that doctor was, I can't remember his name right now, but he was a dick. I'm gonna jump to it with that thing. You don't need a pen. Like literally, my bag tube, I can hold it up like that. Every doctor I showed it to was like, "What the hell?" I'm like, "Exactly." So if that guy's watching, you need to retire, bud. Anyway, so the swallowing thing, I could swallow liquid, but I couldn't swallow anything thicker than like, you know, maybe some pudding, stuff like that. But I didn't even try it, peg tube. I just went with that. And we'll do a whole thing about peg tube and feeding tubes and how to eat as a laryngectomy, but we won't get into that part right now. It's annoying, that's for sure. What else was there? That was oh yeah, your stoma will bleed a little bit. Okay. You got to figure you just had that done probably about what, a month or two before that, right? Your body ain't healed all the way yet. It's healed enough to take this, but it's not healed all the way. So you're gonna get a little bloody. And the big thing is don't freak out. It's you're gonna bleed. That's just welcome to your world now. Mucus and sometimes blood. It just happens. Now you're going to get a little bit of crusty and a little bit of, you know, blood and stuff like that. A lot of people, I know damn well, ain't using just the suction machine. They're using tweezers and Q-tips. Fine. If you're good with it, you know, don't use regular ass Q-tips. You can actually order Q-tips that don't have a bunch of fiber and stuff. So that way you're not getting fibers trapped in there and causing some kind of infection or making it even worse than what it already is, you know? Be smart about it. When you get tweezers, don't get the ones that are really sharp and pointy. Also, if you don't have a steady hand, if you're, you know, don't be dumb. Maybe not that for you, or have somebody else do it for you. You know, when you go to get that dry stuff off, the best thing to do is literally just get a washcloth, get it really hot, and then just breathe it in. You know, don't suffocate yourself. Again, don't be dumb about it. And the reason why I say that is because my first time doing that, I'm like, oh, I can't breathe, forgetting that I'm a fucking laryngectomy. Your brain, you know, you spend your whole life worried about this airway, not forgetting that, you know, this is where you breathe from. It's kind of funny. It took a minute before I was like, stupid. So yeah, don't be mean. And what that'll do is that'll moisten everything up in there. And then you can either wipe it off or pull it off. And then again, don't go crazy with it. Be gentle, be slow. All right. If it doesn't want to come off, don't force it, because that's how you're going to make yourself bleed. Don't pick your scab, kids. Remember that. So, and again, listen to what your doctors are saying. What I just said right now, that's just a personal blah, blah, blah. I'm an idiot. I'm not a professional. So listen to your doctor. But if you do it, don't be dumb. Although I did have a little bit of a fatigue problem, but that was also with the chemo too. Like it is hard when you're doing both to decipher the two. You know what I mean? Because like chemo started to wipe me out towards the end, and radiation started to wipe me out towards the end. So it's kind of hard to tell the two. But the best thing to do though is make sure you're doing some kind of exercises. Okay. No, I'm not talking just like, you ain't got to go out there and power lift, you ain't got to Kevin Hart the thing and shit your pants trying to lift 500 pounds, being a big man. Just walk, simple thing. You can walk around your house for 20 minutes, man, and that's good. Literally walk around your house. It's not that hard. What I was doing, I was going fishing after my treatments, which again, they tell you to stay out in the sunlight because you don't want so much radiation. Plus, it makes you with the chemo and everything in here. It's not good to be in the sunlight. Sorry about that. So, yeah. So my exercises, I was doing a lot of fishing and walking around. We had gorges and stuff like that. That was when we could, but most of the time it was just a fishing thing. Right? I have a garden outside that I was working in, that kind of stuff. Also, do the neck exercises after your laryngectomy surgery, your SLP, and then we'll go over neck exercises and like swallowing and moving your mouth and your neck around and, swallowing at angles, hard swallows, sticking your tongue out and swallowing. Practice those. Do that a lot. Even if it is where you can't eat and you can't do anything with your mouth, still do those. Still try to practice that. Practice swallowing and all that good stuff. Because the more you work those muscles, the better it's going to be for you. And you don't want, like I said, radiation causes scar tissues and stuff like that. You don't want that getting all stiff in there and making it so your mobility is bad, So constantly do those neck ones, man. No matter how far you out, I think, on surgery. Like, I'll be doing them for the rest of my life. I don't care. Just to make sure, like if I had a football helmet somewhere around here, I'd be wearing that right now for a week. Just to get the neck going. Now, remember, just like a sunburn, you're going to want to take care of your skin, right? So I got Aquifer. They'll tell you to get this too, or anything like it. Okay, it is very good. It's for dry, cracking, irritated skin. Very good product, man. I highly recommend that and use it a lot. Like when I started getting my side effects with the dry skin and the burning. That was like we went to PJ's and I bought the bulk one. It came with like the giant one like this, and then a hand size, travel size, and a regular one. And it worked out great. Put that on daily. Like I was doing it like 2 or 3 times a day sometimes. The other thing you're going to want to do is keep your mouth clean, okay? Rinse it out. I know it sounds dumb, but rinse it out every day with baking soda and water as much as you can. What I did is I left it. They also have a drink they can prescribe you, but this is just the easy way to do it, especially if you don't have insurance and stuff. Just baking soda and water. I put it in a jar of it, pre-made already, in the bathroom with a lid, of course. Then every time I went to the bathroom or whatever, and you're gonna go to the bathroom a lot when you're on chemo, trust me there. Every time I went to the bathroom, I rinsed my mouth out, Plus, I drink coffee, so that kind of makes your mouth look bad. So I kind of wanted to try keeping it a little clean so they don't be like, "What's up with your tongue?" Plus brush your teeth and your gums and all that in your tongue. You're going to want to keep that clean so that way you don't get bacteria build up there and cause you a lot more harm than what you need. I've seen a lot of people ask if you can wear a Lary tube while you're getting it done. And that my team actually wanted me to wear the Lary tube. I didn't. Don't be like me. Listen to your team. I didn't do it because it wasn't bothering me. Like what they're afraid of is that like it might swell up and close. So they don't want that, obviously. You don't want that. You'll die. So they look for that. So what I didn't wear my Lary tube, but I did keep track of the size of it. I compared it to a nickel. I even measured it, and make sure that it wasn't shrinking. And I did pretty well. So some people on the other hand, you might get a lot of swelling. So if your doctor wants you to wear a Lary tube, wear the Lary tube. As far as like the table and the machine goes, right? So like the machine, when you lay down onto it, you're going to be a little uncomfortable. They'll do everything they can to try to make you comfortable, you know, pillows underneath your legs, stuff like that. I always took my shirt off, not because you have to, because I wanted to show off. No, because I wanted to help them out. I was wearing polos mostly when I first got my laryngectomy. I was like, oh, I got to wear polo from now on. Not true. You just got to stretch this out a little bit. That's all. So I would take my polo off because the collar would always get caught up underneath and play out. So I was like, you know what? Let me just take it off. And then they always asked, do you need a blanket? You know, I was a fat guy at the time. So I'm like, no. Got to remember to pull the damn finger away from the HME. Anyway. The one thing to keep in mind, though, is when you lay down on a machine, you're laying down like, you know, the machine the table rises up. And you're probably a good 4.5 feet in the air sometimes. I didn't even realize this. I didn't even realize the table had gone up because you don't really feel it. Then it was kind of funny because when it was done, I was like, all right, I went top down, really, whoa, you know, calm down, stupid. So, but yeah. And then again, machine ain't that bad. It's scary. I'll have a video on Larry World if you're interested about the machine, the linear accelerator. And it actually goes through detail how it works, what the magnets do, and how it produces the beams, how they can shape the beam, all that stuff. It was a cool video I found on YouTube. And I'll have that on Larry World, the Facebook group. But all in all, my side effects were easy. I handled it pretty well. I know a lot of you, it's going to kick a lot of your asses. It probably kicked a lot of your asses. A lot of you got out really well. You know, it all depends on the person, just like everything. The one thing I can say to do is go in with a positive attitude, you know, get to know your staff, joke with them, just have a positive attitude. I was rating mine on Facebook. I was giving it like my first visit was like 5 stars, fantastic. Then it slowly got down to like 1.5. Yeah. And I didn't even call it radiation. I was calling it like sunblast or something dumb, you know. The point is, man, if you have a positive attitude, then this whole experience, it's going to be better for you. It's going to be better for you to heal, and better for you to manage it, to deal with it, to deal with other people. It's just a good thing. And that's no matter what you do in life, man. Have a positive attitude. Even if you fail, be positive about it, because a fail is a learning experience. You know, so always look at it like that. Always find a positive in something. Don't look at all the dwelling bullshit, you know. It's not the way to do life, man, really. I mean, if you're already negative, you're going to be even more negative. But try thinking of the positive things. You know, eventually I'm going to do a Letterman style, I think, top 10 Larry list. But we'll see how that goes in the future. So in the meantime, let's get to this interview. And again, like I said, it's a long interview, so you guys better buckle up, go grab some popcorn. If you're driving, make sure you're driving a long way. If you're watching on YouTube, feel free to pause sometimes, like us and subscribe to us. And without further ado, let's get this Larry exclusive going with Dr. Powell. And welcome to the interview with Dr. Powell, a radiation oncologist. We're going to ask him a few questions, get us insight, and let me change hats real quick so I don't look too ridiculous talking to a professional. A little better. Okay, Dr. Powell, welcome to the show.
Hi, thanks, Henry, for having me. Really appreciate it. John Powell, I'm a radiation oncology doctor working in upstate New York, and have to give the disclosure that my opinions are my own, like everybody.
Right. That's something I have to do, is remind everybody's different, you know, all that good stuff. So let's get right into it. Whereabouts are you from?
I grew up in Syracuse, New York. Went to college here and then went through medical school up in Syracuse. Like many people from central New York, when I had the opportunity, I flew south to see what it was like without winter. Spent about 4 years down in Carolina after I finished my residency program. and then had the opportunity to come back. A lot of family around central New York, and having lived in Ithaca for a while, was very grateful and fortunate to be able to move to this area.
Nice. And when you say go to school here, you mean like Cornell or IC?
I went to undergraduate at Cornell.
Cornell University. All right. What did your parents do?
My father was a medieval historian, so he worked up at the University in Syracuse, studied all sorts of things that are hard to have a frame of reference for if you're not a history person. Our dinner time was pretty interesting. I'd hear about the Crusades. He studied the popes, the papacy, and did give me an opportunity to understand that there's a big world out there that's way beyond what my experience is as a young person growing up in Syracuse. So it was cool, and also gave me a sense of academics. Both of my parents, I think, had a strong value on education and pushed me that direction.
Right. Yeah,
my mom stayed home with her 6 kids and helped take good care of us as best as she could. Yeah.
Yeah, that's actually pretty interesting. I love history. So I've always said you can't know where you're going till you know where you've been.
Absolutely.
Okay, so you said 6 kids, you got 6 siblings. Are any of them in the medical field?
No, I have mostly teachers in my family, actually. My father and several of my siblings are teachers. I don't know why I gravitated that direction. Maybe personal experience. The idea that we're here to help people is important to me. That's something that I learned from a young age, and working with people is interesting. I remember thinking, gosh, I'm going to have, this very long period of time where I'm going to be going to work and working regular hours and spending a lot of my time at some employment. What would make that interesting and engaging? Well, if you deal with people, even if the things that you do are very similar day to day, it makes the experience unique because each person's an individual. And certainly when it comes to dealing with cancer, that's a very true thing that we experience all day long, that even if someone's disease is similar to another person's or their treatment regimen is the same, the way different people experience it and how they cope with it and how they manage and get through treatment, these are all individual stories. And so it does make my day-to-day work and life very engaging. And I think it was a good choice, although some days I wish I'd asked for a boring job, I'll be honest, it does happen, but not a lot.
Right. Well, you kind of answered my second question there. Why'd you get in medicine? So why did you choose radiation oncology as a specialty? And was there anything else that you were interested in?
I became interested in oncology, particularly in medical school early on, understanding the science of why these diseases develop. At the time I was going through medical school, there were amazing breakthroughs in molecular biology and understanding what is wrong with cells in the body that they start to grow in this uncontrolled fashion that we could call cancer. Having had personal experiences and then seeing the science that goes into this really drew me in. As I got to work around patients, dealing with people who are facing these diseases is really just a unique opportunity and challenge for obvious reasons. These are some of the diseases that people would least, when you think of your own health, what is a worst case scenario? Well, dealing with cancer is on that list for many people, yet I see a ton of people bring energy and creativity and positivity, and I'm not going to minimize, there is a ton of suffering. Cancers are terrible diseases, but it's a unique opportunity to work with people going through a really hard thing. And that kind of led me to be more interested in working around those patients. So as a physician, if you're interested in taking care of people facing cancer, you can do that in one of a few ways. Primarily giving drugs. Anti-cancer drugs are typically prescribed by a medical oncologist. We would traditionally say chemotherapy, but these days there's a real array of new targeted drugs, focused therapies, immune-related therapies. There is a radiation oncology specialist. There is a doctor whose really entire practice focuses around administering radiation, and vast majority of my patients are facing cancer. We don't treat a lot of benign diseases. There are a few other indications where radiation therapy is used, and the other opportunity is surgery. In surgical specialists, really in general, will focus on specific diseases. They're operating in the same part of the body, being able to remove a cancer process and yet leave normal healthy tissues behind and do those operations. These are all these specialists have things that really help people facing cancer, and there are things that I was interested in I, for a while, wanted to be an ear, nose, and throat doctor because I saw head and neck cancers as being one of the most complicated and diverse diseases. You can have cancer in the larynx, in the oropharynx, which is basically the back of the mouth, the nasopharynx up here, lots of different diseases. And there's so much function that happens in the head and neck area that they are some of the hardest diseases to treat and some of the most complicated cancers, trying to get the best outcome and control of cancer. So initially, I was very interested to look at surgery for head and neck cancer as an opportunity. And this is mostly a joke, but not entirely. One of my mentors said, you know, you're a tall guy. You don't want to be bending over in the operating room for 12 hours a day. You're going to have a terrible back. And not that I, you know, not that that was the only factor, but I really engaged with patients with lots of different types of cancer: breast cancer, lung cancer, head and neck cancer, brain tumors, colon and rectal cancers. All of these diseases pose different challenges. And in radiation, I'm a general radiation oncology doctor. So I treat patients with lots of different types of cancer. And it really, from a practice point of view, it's satisfying and it keeps me involved in different types of cancer. And I have an interesting story, at least to me, interesting. Sometimes life just does things. I was working in a lab in a hospital trying to understand whether I really wanted to go to school and try to do hospital work. I don't like jumping into things without knowing what it is. And so before I applied to medical school, I worked in a lab to kind of be around the hospital and see what happened there and just get a sense of what it was. And my, I'll say, fiance, wife at the time, somewhere in there, needed a job. We were living, and she went to a temp agency, as you will when you're young and need a job. And they said, well, would you do office work? And she was placed in the front office of a radiation oncology department at the same time that I was learning about being the possibility of going to medical school and thinking about that. And I had no interest. I would talk to the residents who were in their training and they'd tell me about what they do. And at that point I said, oh my gosh, you're using radiation. It sounds dangerous. It sounds, you know, kind of unpleasant. Cancer is not necessarily something that is automatically appealing, but I remembered that and I had those experiences. And later on, seeing the technology in our field, how we use radiation to try to target cancer, but also leave patients with the best functional outcome as possible. The situation around my career just sort of came together in those ways, and I feel grateful. I think it's a good fit for me.
What do you think is the most rewarding about your job?
That part's easy. It's the individual patients, the people I work with, the professionals, but mostly the patients who we get to try to meet where they are. Facing cancer is awful. It's not something that anyone would ever choose. No one would ever come to see me in my office if it was up to them. And kind of understanding that, being able to help people in those circumstances as best as you can, seeing good outcomes and helping people when their disease outcome is positive, but also being with them regardless. Cancer is a disease that can often get worse despite our best efforts, and it can be very dangerous and life-threatening, of course. And being present with those people facing those things, I know that it's important for me to go to work every single day and I don't have to question it. And that for me really helps. It really is a good thing, even though we have some days where things we wish would go another way and we see patients go through really hard things. I'm not going to romanticize it. It's cancer, right? But for me, that is probably easily the best part, is meeting people who take their situation that they're in and get through it in one way or another. And particularly seeing you in a situation like this, putting yourself out and just advocating and just helping people broadly who are forced into facing these situations that, like I said, nobody would really want to be in. It's awfully humbling, and I appreciate being here with you.
I appreciate that, actually. I'm just trying to do my part. Okay, so what would you say right now is your biggest achievement in both career or life?
I'm gonna go with family on that one. I have 3 wonderful children, lovely wife, and it's the center of everything, whether it's, you know, sports and activities or just being there with them and helping young people, you know, in our world today. The pandemic makes everything different. It makes people look differently at the world. There's a lot of news and information coming to my family, my kids. They're on social media in one way or another. They get information. You know, my son's not old, he's young, but he knows more about the world, and particularly the things that are not good and happy in the world than I did when I was his age. And that's hard. So I want to be present with them. I want to be a source of good, you know?
It's
hard.
amazing, like how times are different from when we were children to now. Like
Yeah.
when I was a kid, I wasn't worried about like the next technology or anything. I was probably still making mud pies, that kind of stupid thing. It's
Yeah, we
amazing.
spent all our time outdoors and it was a different time. I think every
Right.
generation feels that way too, though. My parents probably felt like, what the heck is this kid doing? He's in a totally different world. And we feel that way. Hopefully they'll be able to grow and move as people do. But I think
Right.
it's an important time and it's definitely the center of my life.
Right.
And my work, between my work and my family, that's pretty much all my time, except for some bike riding here and there.
Right. I was raised by a World War II vet, so I could never complain about anything.
I guess
So
not.
yeah,
I guess.
he lived during the Depression and he was a farmer. So yeah, there was nothing I could complain about.
Yeah.
So all right, now into some tougher questions. What would you rather go for, a burger or a pizza?
I'll go with pizza every time.
New York,
Yeah.
What's your
Thin
go-to?
crust.
Right, what's your go-to ice cream?
I'm going to say peanut butter chocolate, Panda Paws, Reese's Cup, anything with the peanut butter and chocolate combo.
And what's the movie you've seen the most?
That's a good question. It's been a while. I guess I'm going to take a pass on that one. I can't think of one off the top of my head that I've watched a lot. Maybe
Right,
Goonies is the one I would think of.
it's a
Because
good
when I
movie.
was young, it was super popular, but it's been a long time.
It's a great movie. Okay, what's a better pet to you, a cat or a dog?
I like the dogs because they'll go out and run with me. Nothing
Right,
against the cats, but I do have the allergy. So
right.
sorry,
Well,
cats.
cats are kind of a pet anyway. So, what's your favorite music genre?
Um, I love the music that I haven't heard yet. My favorite thing is to find something new that I can connect to. I listen to a lot of music. I love lots of different genres, a lot of American string music, traditional and contemporary. But really, it's hearing something new for the first time that grabs me and getting excited about a band I haven't heard yet, or a type of music or a style of music. I've gone through phases where I listened to jazz all the time and just really dove in, listened to a lot of classic rock growing up and a lot of contemporary music. I love college radio. It's a fun thing to live in a town that has a college radio station because I don't have to do any hard work and new bands just show up and you can hear a song and go, wow, that's interesting. And now you can very quickly and easily find what it is. So yeah, it's
Yeah,
whatever's next.
I think the college radio cracks me up. They play all kinds of stuff, man. And back in the day, it was even more like nothing was mainstream or anything like that. It's kind of cool. All right, so now we're going to get into the questions that are more about your profession and stuff like that. In an earlier episode, I explained a general idea of the history of radiation. Now, there's many types of radiation, too many for us to ever go over on this episode. I couldn't even do a whole episode on the different radiations there are out there. But we're going to be focusing on ionizing radiation, which is X-ray, pretty much is what it is, X-ray radiation, or what do they call it, X-ray radiation, right?
Exactly right.
This is used for like your CT scans, your PET scans, of course, your X-rays and radiation therapy. So in layman terms, can you give us a damn the difference between all of them? Like, is it just more waves? What's going on there that makes it so like one's for a PET scan, one's for an X-ray?
Yeah. So radiation is basically energy. And different wavelengths, different energy levels have different characteristics when they interact with tissue. Generally, diagnostic X-rays are using lower energy and much lower doses. What we've found is that many cancer cells are susceptible to higher doses, and the characteristics of radiation therapy are really important. Where we want that dose to go in the human body as specifically as possible really determines how useful it is as a treatment. So the history of radiation is both developing ways to deliver radiation and also trying to understand how much radiation it takes to kill cancer, to try to eliminate cancer or control symptoms from cancer, and also where the risks and the side effects are. I think automatically when people hear about radiation, it's obvious that you have to be concerned about that. Radiation exposure poses some risk. It turns out there's radiation all around us. We're bathed in radiation all the time. It comes terrestrially. It's a part of our lives, comes out of the ground. yet that's pretty small amounts. Harnessing it for medical uses, whether it's diagnosis or treatment, we have to be real concerned about potential risks. So the treatment that I give is external beam radiation therapy. Exactly as you said, it's an X-ray treatment. This technology gives us the ability to essentially shape and sculpt the dose. There's a lot of jargon and a lot of acronyms, and you've dove into a lot of that. And even for myself, when I was learning this field, I remember trying to get involved. And as a learner, the whole point is that you don't know, but yet there's a whole different language. In medical school, they teach you medical language. A lot of it is Latin, but they don't teach you about IMRT and IGRT and these different acronyms that are really very specific to our field. And basically, there's a few components. It's being able to deliver the radiation to the area that I'm targeting and really minimize dose exposure around normal healthy tissues. That's to reduce risks and side effects. The other aspect, that's really a planning process. The other aspect is being able to deliver the treatment really, really accurately. So we want to make sure that the patient's positioning is the same. I can see your mask hiding back there. That's a hard part of that treatment, but it also gives us really accuracy down to hopefully a couple, 2, 3, 4 millimeters in terms of the reproducibility of the radiation, so that we can try to really make sure it's going where it needs to treat the disease, and also avoid, again, the normal healthy parts of the body as much as possible. We've found that spreading out the radiation dose through many small treatments is a strategy to help get a better advantage. Cancers are really susceptible to this type of radiation because it damages their genes and DNA. And when cells are growing quickly, they have to copy the DNA. They have to make an entire copy to form 2 new cells. And when they go to copy the DNA, if it's been damaged by radiation, those cells die off. Well, normal healthy cells have reasonably good DNA damage repair mechanisms, so they can repair and heal from the damage radiation's doing, and you can get a pretty big advantage by giving many small doses spread out in time where normal tissues are recovering and cancer cells have a cumulative damage profile. The result is that it's a really hard schedule for a lot of the treatments I give. Some short courses of radiation are used, some radiation is given as even a single treatment. And there's also, as you alluded to, other ways to give radiation. But many of the treatments, we're having patients come daily, Monday through Friday, 5 days a week, for therapy over the course of 4, 5, 6, 7, or 8 or more weeks for different scenarios. The treatment process is probably only about 15 or 20 minutes daily, sometimes a little longer, sometimes a little quicker, but that schedule is just difficult. And also it stretches out the process in terms of the patient's experience. Radiation side effects, because I'm giving a small dose daily, build up gradually during the course of treatment. Because the treatment is X-rays, most people don't really see or feel anything when the radiation dose is delivered. There are some exceptions, but for the most part, people experience side effects gradually during treatment. Maybe a week or 2 into therapy, side effects start at a low level and gradually increase. They really depend on how sensitive each tissue is to radiation. The way that I think about side effects, and this is a question so many of my patients are interested in, so I really tend to emphasize it when I talk to people about this treatment. People want to know how they're going to feel. They want to know what risks are associated. Again, it's automatically scary, so we have to be really straightforward and honest with people. And I don't want to sugarcoat. I don't want to tell someone a treatment is probably going to be reasonably easy when most of my patients who are going through it are telling me that at least for a period of time, it was pretty difficult. Their recovery was gradual. It took some time. Some people go through a treatment and have a relatively easy time. Side effects affect different people differently. Some people have very severe side effects or even long-term or life-changing side effects of cancer and cancer treatment, including radiation. Most treatments are designed so that an average person can get through the full treatment and get the benefit and recover, hopefully well. But some tissues are really sensitive to radiation and some don't recover. The way I think of side effects is both during treatment. These side effects we refer to as acute. They build up gradually during the course of therapy because of inflammation in the treatment area, and then that inflammation goes away. There are also late side effects or long-term or permanent effects. Any tissue in the body that radiation touches can be damaged. Probably the best way to think about how much that risk is, a common side effect should be something people can live with reasonably well. A very severe life-changing or life-threatening side effect should be really, really rare. there's been a huge amount of research done to understand how much radiation dose can be given in each different circumstance to try to maximize the benefit and minimize the risks. But these are difficult treatments, and the radiation's inflammation really can be very, very difficult in terms of how the person feels. And coming around to head and neck cancers, this is where we live. This is where our sensory is. This is where our experience is. And so as those side effects build up, it's just one of the more difficult treatments. Head and neck cancers also are very responsive. So we see improved outcomes for many, many patients by going through radiation in head and neck cancer. But I do think of that as being one of the more challenging areas of the body for patients to get through treatment and recover. Lots of people have dry mouth long-term, swallowing difficulties, difficulties with taste, lots of impacts in terms of dental health and other things that can stay with them. And so probably understanding that is a big concern for people who are thinking about this as a possible treatment that they may need or may be recommended for.
Can you explain to people why the cancer cells break down quicker than your good tissue?
Yeah, there's probably some mystery here. So my field, radiation therapy, to me, that history that you alluded to is amazing. When radiation was first being discovered, the Curies finding isotopes, a fellow called Rankin who discovered X-rays, they called it an X-ray because X was the unknown variable, supposedly. At least that's what I've heard. They really didn't know what they were dealing with, but people started applying this phenomenon without knowing what it was to the cancer problem. At that stage, this is maybe 120, 25 years ago, really we didn't have a lot of cancer treatments, maybe almost none. And so anything like this, very quickly, with very little knowledge of what they had in their hands relative to what we know now, they started applying this to cancer and could see that cancers were susceptible. Since then, there's been endless amounts of research. There's a lot of emphasis on classical radiobiology, how radiation affects tissues, that emphasizes damage to the genes in cancer cells. They don't repair the damage as well. That's part of the reason why you see that advantage. And also because cancer is made up of cells that grow at a very rapid rate, it compounds the damage. They have to divide their DNA more frequently than normal tissues, and so they tend to die off more quickly. These days, there's a huge emphasis on a much more complicated understanding of cancer in terms of molecular biology, what genes are active, what proteins they make, what the environment around cancer cells. Cancer cells develop resistance patterns. They have very specific abilities that allow that disease to proliferate, to grow in the body despite our greatest efforts. Some tumors can recruit their own blood flow to support their rapid growth. So people have developed drugs that can interfere with that. Understanding that molecular biology has led to huge amounts of improvement in cancer drugs, immune-related therapies, which when I grew up in oncology, this was like the holy grail. It was the thing that we didn't have that we all wanted, a great way to turn the immune system on to help fight cancer. And in some of the most difficult cancer problems that we deal with, we now see real impact with immune therapies on patients. It's truly amazing to me. And again, it's dangerous to over-romanticize. These are still terrible diseases, and they can become resistant even to targeted therapies, even to immune therapies. They're not perfect drugs, but we're seeing a lot of progress from understanding, I think, the molecular biology and the genetics of tumor cells and normal cells. And that's being studied in radiation as well. For example, there's a lot of interest in understanding how the radiation that is delivered to a tumor generates an immune response. It causes inflammation. And so tumor cells may become more obvious to the immune system because they've been hit by radiation. And there's a lot of interest in combining immune-related therapies with radiation, where you might get a synergistic effect, an additive effect, because the radiation makes the cancer potentially, quote unquote, more obvious to the therapy. We really don't know. The hard thing about the cutting edge is that we have to do the clinical trials and the research to really prove. We don't like to have a good idea. We like to have good data, meaning lots and lots of people who've been treated by a regimen and proof that it's more effective and or safer than other regimens. So there's a lot of emphasis on clinical trials, and these research studies do take a lot to design and to implement, but I think that molecular biology understanding is really in radiation adding to and complementing the more traditional DNA damage model. And so hopefully what that means is that we're going to be able to be more specific There are situations where we've given really aggressive radiation treatments with high success rate, and now there's researchers looking at trying to reduce the effectiveness, maybe drugs, to try to reduce side effects and toxicity. That's happening in oropharyngeal cancers, which refers to the back upper part of the mouth, throat, the base of tongue, and tonsil, for example. Many of those cancers are driven by the human papillomavirus, which for whatever reason seems to make them more susceptible to radiation. And so again, because of side effects, we're trying to find ways to get the same good success rate of treatment, but also hopefully reduce the toxicity. So there is a lot of research in that molecular area trying to understand what's really happening at the smallest level within cells. And I think there's still a lot of progress to be made there, but I'm optimistic.
Before or when you're going to get your treatment for your laryngectomy, you get this nice little mask like the one you mentioned. I assume that's for all head and neck cancer, right?
Yeah, pretty much anytime we treat with radiation therapy, we want to make sure that the area of the body that we're treating is adequately immobilized. The radiation treatment is customized for each person. The radiation comes out of the machine exactly the same each day. So positioning makes a really big difference. Unfortunately, the neck is one of the most mobile parts of our body. And so having good immobilization, we have used these masks for pretty much all patients, whether I'm treating brain tumor, head and neck cancer, cervical spine tumors. Tumors in the spine around the neck area often require a mask. There are some lymphoma treatments that I give that include both the neck and the chest. And so we want to immobilize that entire region. At other areas of the body, we have beanbag molds that a patient will lay in, and then the air is removed. So it makes a form or kind of a mold that the physician can be reproduced. Lots of different techniques. And then in addition to immobilizing, our treatment machines are getting much more sophisticated in their ability to check the internal anatomy. I can see with scans and x-rays the actual target in many cases that we're treating. So we're not just looking at the surface of the patient, which we've done traditionally with skin marks, people say tattoos, or other areas. We try to put, for head and neck cancer, we try to put most of those marks on the mask, although often for straightening, we'll have one on the middle portion of the chest here.
The one right there.
And that allows the therapist, that allows the therapists to make sure that each day the patient's position, the lymph node regions in the neck that we're targeting, we want all of that to line up just so the radiation goes where it needs to. The mask, again, this is probably one of the more difficult areas. It's very claustrophobic. It automatically is stress-inducing to be.
Yeah, everybody complains. Everybody complains about the mask. I personally, I didn't find the mask too bad. I found the MRI machine way worse. You know what I mean?
Yeah. People,
especially making the mask. When they put the mask over you, it's warm and kind of soothing. Whatever. And I got to the point where I was able to lay into it and know I was right. You know what I mean? Like you can tell where your face is lining up and everything.
Yeah, I think people deal with it reasonably well in general. Some people have problems already with claustrophobia. I've seen all kinds of challenges, and we want to help someone who's dealing with this regardless of what their situation. For some people, it's medications. For pretty much everyone, it helps to explain what's going to happen and give people some time. People don't want to be rushed. This stuff's automatically scary. Walking, down the hallway knowing you're going to your first radiation treatment. I think there's a lot of things going through people's mind, and most of them probably are not what they want. And then we come and bring this mask in. So we're very mindful. The therapists who give these treatments are professionals. They've helped a lot of people deal with similar situations. Part of it is being really expert and making it go smoothly and quickly. Part of it is explaining it. Part of it is probably tough people dealing with things. Prayer, meditation, deep breathing, white knuckling it. Just get me through this. I've had a lot of patients explain after the fact, looking back and seeing that mask. There's actually a relatively well-known NPR special from I think years ago now, where they had people who'd been through head and neck cancer specifically talking about the mask, and people describing, running it over with a bulldozer or taking it out to the firing range and putting it where it belongs, and other people making art and making creativity out of it. I think I'm amazed by the coping mechanisms that people bring to hard situations, and it's our job to meet them there and provide what help they need. So I've had patients who said, Doc, I'm not going to be able to, I want treatment. I want you to help me. I'm not going to be able to get on that table if I don't have medicine that's going to help with the anxiety and the stress that I'm experiencing. And so that's okay too. The treatment's probably only about 15 minutes. because it's daily, lots of people tell me that it's not fun, it's not easy, but it did get a little bit lesser. One of the challenges in head and neck cancer is that the treatment causes dry mouth. It causes mucositis, which is inflammation along the mouth and throat. And part of that is this really thick mucus that's impossible to clear out. Secretions you can't swallow, you can't really get them up. And it's often described to me as one of the hardest side effects of radiation. That, in combination with having to lay flat and being immobilized, for some people is really just unmanageable. We're working with suction for some patients and trying different medications. And I think that may well be one of the hardest in terms of process for treatment that people experience. And, you know, people do get through it, but it is awfully challenging.
Yeah, the art part of it is kind of, I found a video online. I'm actually going to show it at the end of this. At the end of all this episode, I'm going to have to put masks up that people have done with them. There's a hospital, and I cannot remember the life of me right now where it's at. But the art students went in and took all the masks and made different things, and it looked like art paintings and stuff like that, like models. It's pretty cool. But for the most part, everybody I've talked to is saying they throw it in a fire or something, something dramatic. Okay, so you get an MRI before you get this done, and that's to locate the tumor or the cancer, and that way you guys can shape the radiation machine in your accelerator to the size and the shape of the tumor. My question is, were they always able to do this, or is this something that, like, within the last 30, 20 years?
Yeah, it's a great point. So I'm a radiation oncologist. There's an entire other medical specialty of diagnostic radiology. For me to be able to treat patients, I need to know where that disease is as best as possible. So there is this array of diagnostic testing. Unfortunately, it means that the medical process for a patient is often a whirlwind. You need these 5 scans, you need to see these 4 specialists, you need these 3 procedures done. It's pretty overwhelming. A PET scan is a metabolic test, so it maps out the metabolism of tissues in the body based on how much energy they use, how much sugar they take in. All the cells in our body burn glucose for energy, but cancer cells, because they're growing much more quickly than normal cells, they take up more of this radioactive glucose tracer. And so we can map out even small areas of cancer more effectively than traditional imaging. Around the brain and the head and neck area, there's a lot of interest in the nerves and the soft tissues, and MRI, which is a picture made by a very, very powerful magnet. It's not actually radiation exposure. It's actually using a magnet that changes the water molecules in tissues in the body, and then it gathers the energy when the magnet releases to make a picture. I'm going to say magic. That would be my word for MRI physics. We do have to learn some of this when we're in training and that, and it's just a remarkable thing that people have been figuring this out. It's also, as you alluded to, it's a really hard test. It's a small tube. To get high quality pictures, you have to have that magnet right there. For whatever reason, something about the power of it, it makes kind of a jackhammer noise, kind of right in your ears. And it's just, yeah, as you say,
what
right.
I love about it is they give you music to listen to. You can never hear the music like that.
Yeah. Having very accurate imaging of what the person's cancer problem is really allows us to be specific, to understand what the treatment should be based on where the cancer is. And with regard to radiation, exactly as you said, I'm mapping it out based on these tests, based on examining patients, sometimes following surgery, based on what's found at the time of an operation. I need all that information in detail to understand what tissues are at risk. Each cancer has a pattern or a behavior. None of them are perfectly predictable, but in many ways we do know what areas are at risk for harboring cancer for a given type and what areas are probably not likely to have cancer. And so I can tailor my fields not just to the results of all those imaging studies, but also to an understanding of what the disease is likely to do. And of course, my treatment is not going to be effective if it doesn't entirely target the area at risk. And in head and neck cancers, many of them have the tendency to spread into lymph nodes. That spread leaves the patient in a situation where radiation needs to be administered to a broad area for the treatment to be effective. And that's part of the reason, going back to side effects, we have lymph node chains in both sides of the neck that go from essentially behind the ears down to the collarbone. And many head and neck cancers, even those that have a very good prognosis with treatment, have a high risk of lymph node spread. So I'm intentionally, in many circumstances, covering these broad areas with radiation. The dose levels are different. There's the amount of radiation needed to treat an intact tumor and try to kill it off with radiation. There's an amount of radiation needed to try to kill off microscopic cancer cells that is lesser. So again, we're trying to do enough to get the best prognosis, but also do the treatment carefully enough and conservatively enough to leave people with the best prognosis. This is that sensitive area where side effects come from.
Were they always able to do it since the beginning of the machine? Or?
Yeah, probably. I'm going to say you could fact check this easily. I'm doing it off the top of my head. CT scans becoming much more available around maybe late 70s, early 80s, and MRI pretty soon afterwards. I can remember when PET scans were just being developed, and we didn't have access to them. And this is, less than 100 years ago during my training. And so, yeah, there's a constant and ongoing effort. One of the things about PET scans is that it's a map of glucose specifically, and that works well for some cancers. It's an excellent test for head and neck cancers and lung cancers and lymphoma, for example. But for prostate cancer, it's not really a very good tracer. The bladder is where the dye is excreted. People urinate out the tracer that's injected, and so the bladder and the prostate gland are right next to each other. So you can't really see the prostate, and prostate tumors don't tend to be as fast growing. So over the last, again, 20, 30, 40, 50 years, people have been looking for specific tracers, and we're now seeing a number that have become FDA approved that can map out specific characteristics of prostate cancer and give us one of these very high resolution diagnostic tests to really understand more sensitively where cancer is active in the body, and knowing what the disease is doing and where it is really critical, obviously, to guiding good treatment. So there is an ongoing effort to improve these treatments, different technologies, always changing. There's constant research at many, many hospitals across the country and across the world, as well as in industry, to give us better imaging. It's really central in oncology to have the best images, and it's going to continue to change. And one thing I can remember when you asked that question is when I was a student, someone passed me a film, an X-ray film of a CT scan that has these individual slices next to each other. Looks like blocks. So you're looking at each slice of the body. Now we look at it on a computer screen, so you can slide the image up and down and show a volume. I had to take that CT and put an X-ray next to it of the person and draw where the kidney was, looking and measuring on one image, two-dimensional, drawing onto another, so we knew where the patient's kidney was, and we would theoretically try to protect it. So that was commonly done in our field, not really that long ago. And now all this imaging is digital. We fuse these images. So you have a PET scan, an MRI scan that goes on top. We make the mask, we simulate the patient, or we scan them for their radiation planning, and we put that image on top. So I have all these images in software. And just like technology, I use the analogy when people ask me about radiation technology of your phone. Think about what your phone was 10 years ago. Think about 20 years ago. Think about 30 years ago. Our field, hopefully we're doing better than cell phone technology in terms of putting resources into software and hardware that allows radiation therapy to be more accurate, more precise, and safer. And I really see those changes in technology helping patients daily. It helps us to be better at what we do. It gives us new opportunities. We can target, for example, very small areas of the body with much higher doses of radiation, which for some cancers is very effective, and it also shortens the course of treatment. And really, we probably couldn't have done that safely if there was more uncertainty of where the radiation was going. So technology is really very, very central, obviously, to what we do here. Unfortunately, I see it as an ongoing process of improvement.
Yeah, I was actually amazed, just like what was it, 12 years ago when they gave you an X-ray on a disc to give to another doctor. I was like, that's amazing that it's on a disc. So the fact that now you can just email it to somebody, you guys can share it within a network with each other. I think it's amazing where we're going with that, actually.
The software works, it's amazing. And then when it doesn't, we all wish we had a film jacket. But in general, I see a lot of progress.
So explain how important exercise is during treatment and after to help combat the side effects? What kind should they all be doing, regardless how far out your treatment is?
Thank you for that question. That's something that I personally see making a huge difference in the lives of people facing cancer. Everyone's circumstance is different. And what exercise means is probably different for different people. Our research, and this is something that is being studied ongoing, we see significant improvements in terms of side effects for people who are active. Fortunately, it seems like relatively modest intensity exercise, but regular is where a lot of the benefit is. I take care of some patients who have been high intensity athletes, people who have run marathons and who have a regular exercise schedule, and a cancer diagnosis shows up and that's what they're used to. And I take care of people who are facing many different health problems at once, and even doing basic day-to-day activities is a challenge. And so there is this wide spectrum. I tell people what you're able to do today and what you push yourself to do today, you're likely to be able to do tomorrow. Part of it is about quality of life as well. One of the hardest things to address for people facing cancer, in our jargon, we refer to as psychosocial distress. Cancer is automatically the kind of thing that shocks people, that leaves them not knowing what to do, makes them question everything. Fear, worry, anxiety, depression, these are common experiences for people facing cancer at a high intensity, whether someone has faced those as an ongoing problem previously, or if it's really focused around the diagnosis. And receiving proper medical care is really important for people with regard to mental health and psychosocial distress. But it turns out that exercise, along with proper care, counseling, family support, lots and lots of things that are important to help people get through this stuff, exercise improves distress in a very interesting way. In a significant amount, not high intensity exercise. I think that there is a challenge facing cancer where people have lost control. A lot of us spend a lot of our time trying to control as many aspects of our life as we can, trying to make our life move the direction we want, trying to get our job to do what we want it to do. And cancer pulls the rug out real bad for a lot of people. And exercise is something that you can control. You can say, I'm going to get up and I'm going to do what I can these days. I have to be careful, because people pushing themselves really, really hard will find times where they are too weak and really not safe in terms of fall risk to be able to do much. You can do chair exercises. You can get elastic bands and get some cardio and get some blood moving, even without doing anything that is too strenuous. It's not the perfect fix. It's not the only thing that helps, but I really do think that for probably all of us, with or without cancer, but especially for someone facing a challenge as difficult physically and physiologically as cancer, exercise really does make a difference. And again, my good news is it doesn't have to be real intense. You don't need a gym membership. Just walking 30 minutes a day at a comfortable pace. In research studies, it's often done 3 or 4 days a week. I like to joke that's because grad students need the weekend off and they need one day to do data analysis. I tell people do 7 days a week. That way you don't have to figure out if it's today or tomorrow. And if you miss a day, you're still getting 4 or 5 or 6 days a week. But regular is important. There's something about steady. I run around all the time at my office. I'm always here, there, and everywhere, but I might be running for 2 minutes and then I'm sitting and my heart rate doesn't stay elevated. I think there is something about an ongoing period of time, again, maybe shooting for around half of an hour. I'm sure there's not a magic at 30 minutes that isn't there at 15, if that's what's right for someone. But trying to do something that's sustained is probably helpful. And the other part of that is physical therapy, not so much cardiovascular, but trying to build balance, build strength, build mobility. For head and neck cancer patients, one of the long-term impacts of surgery and radiation is scar tissue that forms, and that can take away function. People have difficulties in terms of range of motion in the neck, both the jaw as well, trying to open the jaw properly, which can interfere with eating. And part of it is time and healing, and part of it are things that people do on their own. I see naturally my patients are stretching out where it feels tight. A lot of us are used to having an injury and rehabbing parts of our body that aren't working as well as we would like. But a lot of it, that progress is better with with a physical therapist, with a medical professional who can assess where the person is, what are the goals over time, and what are the best exercises and strategies to get there. So we refer a lot of people in terms of head and neck cancer, physical therapy, speech and language pathology, swallowing therapy, speech therapy, which you could tell me a lot about, right? You know as much or more than I do about these processes, and they really make a difference. I see a recovery, and I don't want to put it on the person to fix the situation. You can do everything right, and some people are left with problems that don't get better despite incredible efforts. But I do think it's a situation, particularly in the first maybe 2 years after treatment, where there's a lot of potential improvement. And as scar tissue forms, and the further out you get, the less likely it is that you can get that range of motion back, for example. So we really do emphasize oncology rehabilitation with our patients as much as possible, so that they can get the best long-term quality of life and outcome.
Okay, on to the next one here. Is there a cancer that radiation can't be used for?
There are plenty of situations where radiation would be rarely recommended or not part of a standard of care. Cancers are diseases that can be rare and unpredictable. And so there are some cancers where there's very little research to know how helpful it is. And I've seen patients referred for consultation to discuss radiation for diseases where there's almost no data, just very rare tumors and unusual circumstances. We really don't know how much the treatment works. Diseases of proliferation, of cell growth, seem to have some potential sensitivity to radiation. For the most part, oncology and medical practice, at least in the preferred situation, is evidence-based. So before I ever treat a patient with radiation, I want to know that there's strong data and research telling me that it's going to be helpful, what the risks are going to be, what the treatment should be, how much radiation and how it's given. For common cancers, that research is very, very broad, thousands of patients participating in clinical trials over many, many, many years. But for rare cancers, that research is harder. There are plenty where it's very uncommon to use radiation, but I don't think there are a lot of cancers where there haven't been circumstances where it might be helpful. Probably about 2/3 of people facing cancer receive radiation at some point in their treatment. Many of those are trying to help control or eliminate cancer, and many of those treatments are trying to help and eliminate symptoms. And that's a circumstance where radiation can be helpful for lots of different cancer problems. If there's a localized area where the cancer is causing pain, or a bleeding problem or another symptom, some radiation is often used for symptom control. In the use of radiation to try to control and eliminate cancer, that's usually more specific. That's usually a protocol, meaning a combination of treatments or a specific treatment regimen that's been tested in clinical trials and proven to be effective. We don't want to expose patients to a treatment that has the risks and side effects of radiation without good science and research telling us how much help it's likely to be.
Let's see here. Is there a chance of cancer reoccurring in the exact spot? And if so, how often does this usually occur? What's the percentage?
We worry about cancer spread and recurrence locally, meaning where the cancer problem was. In our jargon, we talk about regional cancer. That's usually in the lymph node areas, for example, as I was describing in the neck with head and neck cancers. And we talk about distant metastasis or spread of cancer through the bloodstream. The jargon around health and oncology is confusing, and spread to a lymph node for some cancers may not have a big impact on their prognosis. They may have good treatment options and a good likelihood of eliminating cancer. That can be referred to correctly as a lymph node metastasis. But if we're not too careful and we say the word metastasis and a patient hears spread to another organ, like the lungs or the liver or the bones, these are often difficult cancer problems to eliminate or impossible for many types of cancer. Even with the best treatment, we may just be controlling that cancer problem for a period of time. There's always exceptions, but we want to have the same expectations as our patients. So each cancer, each type of the body, we talk about cancers based on the organ they develop in or the area of the body, and we talk about them based on the cell type or the origin tissue that it developed from. For example, you can have a lung cancer that is an adenocarcinoma, or one that's a squamous cell carcinoma. They're both lung cancers. They could be the same stage, but they are different cells in the body that became malignant or developed cancerous growth. Most head and neck cancers are squamous cell cancers, but for example, saliva glands have a whole array of different cancer types. Most of them are adenocarcinoma. This is the kind of stuff that drives well-informed patients who are trying to understand their situation crazy, because the jargon is tough. There's not a good way, even with the Google, you find huge long lists of hits if you start putting in these words off your pathology report. So it's our responsibility as physicians to try to explain. Each cancer in each part of the body has a predicted natural history or a way that it behaves. Some of them are just not likely to grow or spread. Some of them are very likely to spread rapidly. And so we try, based on our experience and knowledge, to predict and understand. None of those predictions are perfect. And we do see exceptions. We see people who have cancers that have a very bad predicted prognosis, things that are often life-threatening to people quickly and have very few long-term survivors. But they don't have none. They have very few. And we don't always know why one person was able to make it through a cancer problem that is life-threatening to almost everyone else with the diagnosis. I've also unfortunately met people who have heard, relatively speaking, good news about their prognosis. People say, this was found very early. Your cancer is likely to be eliminated. You need treatment, but 98% of people, the cancer goes away. That leaves 2%, 2 out of 100. And there are many, many cancers. There's about 66,000 head and neck cancers diagnosed in the United States each year. So 2% of people who are outliers, who are having an experience that's way different than our statistics, that's still a lot of people. Cancers are unpredictable diseases. It can come back locally, right in the same area. I've had, unfortunately, patients who had radiation therapy, and I gave a full dose treatment to a cancer, and it grew in the midst of therapy and just did not respond. In terms of radiation therapy, there's been huge amounts of research trying to understand radiosensitivity, or how cancers respond better or less well to treatment. And there's still a lot of variation there. There's still a lot of uncertainty. I can tell you what is average, and I explain that to a person when I talk to them about treatment, but I can't promise them that they're going to be in that middle of the range. They might have a much better prognosis. Personally, their experience might be better than predicted. It certainly could be worse. It's just, unfortunately, and I think that's also one of the hardest things about hearing, and people want information. They want to know what's going to happen. My patients are used to, in 2021, having access to detailed information. We can pull out our phone, and most people know how to sort through things that are useful and accurate. They can find information from good cancer centers, not-for-profit organizations, government-related cancer organizations. These are places where people know that they're getting good quality information, but they don't know, or they can't find, where their situation fits in to this huge amount of info that's out there. So again, my job is not just to make good radiation therapy and help people with side effects and recovery. Often information needs and questions about putting themselves in context and understanding what this disease means are the most important thing I can do to help someone. And often I don't know. I don't know when I treat a patient if they're going to be fine and things are going to go okay, and they're going to tell me that treatment was hard, but they managed okay and recovered well, or if they're going to have a real bad side effect or a life-threatening complication because of other health problems. So we watch very closely. That uncertainty, from my point of view, means that people facing cancer and going through cancer treatment need ongoing surveillance. We have weekly visits with patients, lots of ongoing medical testing. It makes the treatments pretty overwhelming. Again, day after day and week after week in my office, and a lot of ongoing supportive care and a lot of ongoing medical care to get people through it. Really is not an easy thing by any means, but with that, it allows us to react to that uncertainty in real time and try to make adjustments.
Right. It's going to be annoying sometimes, though, when people looking up WebMD or whatever. You know what I mean? Like, how much of the misinformation does that mess with? How much misinformation is people bringing to you? Do you know what I mean?
Yeah, it's a really interesting question, and probably in our society, it's a much more broad question. I'm going to keep focused on oncology because it's what I know about. My impression is that most people bring me information that is generally of reasonably good quality. I also think that people are aware. People don't want to tell their doctor what they're doing if they don't think their doctor is going to accept it. There's a problem where I'm not going to get full and honest disclosure from my patients if I don't give them the feedback that their perspective on their health is valuable. And different people have different perspective on their health. They have different traditions and they have different ways of looking at it. I live and work in a place that has a strong tradition of integrative health. I like the word integrative to describe different traditions of health that are meant to improve people's outcomes. Even if I wasn't trained up on them in medical school, which many of these other traditions are not well represented in medical education, that's improving. I bet it's way better now than it was when I was going through my training. We have data suggesting that easily 2/3 of people facing cancer take advantage of some form of integrative care. And so we follow our patients. If they are doing things in large numbers, I need to know about them. I don't ever like being the least informed person in the room. I don't want to say to my patient, hey, I never heard of that. Probably it's not a thing, because it might be, just because it's not part of my tradition. When we test integrative modalities in research studies, which is a little slow and it's a hard effort, but there's a lot of it happening, we often see real and significant benefits. Most of it, from my perspective, the biggest benefits seem to be in symptom management. Acupuncture is a really good example. There are a lot of good clinical trials studying acupuncture in rigorous scientific ways that shows that it helps people in terms of recovering from cancer and cancer treatment. And so I can endorse that. Hospitals have training programs in oncology-related acupuncture. Not many, not enough. Access is a challenge, but nonetheless, we want to bring that together. So overwhelmingly, I see people generally finding reasonably good information. It's probably also my job to be specific. If someone brings me a concern and that research has been done and the modality they're talking about really doesn't seem to be any good, if it doesn't seem to help people, I've got to be an honest person and I've got to have a hard conversation and say, that thing has been studied. We're worried about this, that it might actually be worse. One good example is antioxidants. They've been studied in oncology a significant amount. This research is controversial. People on both sides, smart people, scientists, have different perspectives on how cancer cells respond to oxidative stress and how normal cells respond to oxidative stress and how we might use this to improve cancer outcomes. Radiation kills cancer cells by creating free radicals within the cell. That's basically a water molecule that has a hydrogen atom removed, so it develops a negative charge, and that charge is what interacts with DNA and actually does the damage. Normally, we worry about free radicals damaging our DNA and causing problems. So we're encouraged to, for example, drink green tea and eat blueberries that are rich in antioxidants in a normal state of health. And that's probably fine during cancer treatment. But if you take high doses of antioxidants, the concern is that you might make radiation less effective. And researchers, scientists, conventional medical folks wanted to try to reduce side effects from radiation by giving antioxidants and did that in a clinical trial of radiation for head and neck cancer. And they found that maybe side effects were a little bit less, but that they lost some effectiveness of treatment. And so we're trying to optimize our regimens to cure as many people as possible. We don't want to be unintentionally dialing it back, even if it makes side effects slightly lesser. We've been looking for radiation sensitizers, meaning drugs that make cancer more susceptible to radiation, and radiation protectors, meaning drugs that protect normal healthy tissues. There are examples where compounds like this have made it into medical practice for substantial periods of time, and then researchers really debunk it and show that it doesn't do what we want. It's a hard area. Cancer cells are in many ways very, very similar to normal healthy cells. They are cells from our body that have gained these abnormal mutations that drive cancerous growth, but they're very similar. So it is hard to target. I do discourage patients from taking antioxidants in more than recommended levels. They could take a daily multivitamin. As far as I'm concerned, and it's probably reasonable, but high doses of antioxidants might make their treatment less effective. So that's one where we have national guidelines that recommend that we discourage patients. So that's easy for me to tell the person, this has been looked at enough. And yet I have patients who tell me, no, I understand this. I'm working with somebody who's going to give me these antioxidants because they're going to make me better off. There's a lot of uncertainty in health, and I don't think that I know everything. I want the person to know what I know and be as well informed as possible and to make the best decisions they can for their health. And living and working in Ithaca, I see a lot of people bringing me things that aren't in the textbook in terms of conventional medicine. Hopefully, most of them help people to get through treatment. Maybe that nidus of control, they're taking control over their health. People really want to know what the anti-cancer diet is. There's endless books written on this. There's lots of bestsellers written on this. And yet finding specifics in recommendations for diet that reliably prevent and eliminate cancer is hard. Probably there's a lot of impact of diet on our health. I'm sure of it. I try to eat a healthy diet myself.
Oh yeah, diet, everything we do, man. Like ever since I've done this show, like I was telling you my last visit, ever since I've done this show, it opened up my eyes to a bunch of different things, from environment to like what we eat, what we cook with, what we drink out of, like everything, man. It's insane. Like the breathing of the air seems like it causes cancer nowadays. So it's insane. And as soon as I got cancer, that's when I started seeing all the magical pictures showing up on Facebook and everything. So
yeah, there is a problem of marketing. Cancer patients are broad. There's many of them, and people would do anything to get rid of cancer.
Right,
and
right.
So
Yeah, they're looking for any kind of help they can get, and these guys are just vampires on them, and it's just sad. Really.
Yeah. And it's hard for people to know. You can make things look good, even if there's not much to them, and you can make them very expensive and people will still buy. So that is out there as well. Fortunately, I don't think, hopefully not a lot of it. Yeah, go ahead.
Okay, so what are some of the things you should avoid during and after the treatment?
Yeah, so I'm going to go with the number one on this list, and I'm going to climb way up on the soapbox here, and I'm going to go after smoking on this one. That is really just most critical for many, many patients facing cancer. And the reason I like to make a big deal about it is that it's very, very difficult to quit smoking. Lots of cancers are associated with smoking history and the risk of developing cancers caused by tobacco or other cancers. I have people who develop cancer that's completely independent who are then reevaluating their health, and they realize that they're going to have to take some actions to become healthy. You can eat any diet in the world. It's not going to make the difference in your health as quitting smoking. I will go to bat on that one every time. It reduces side effects from radiation therapy. People who manage to quit smoking before treatment have less side effects, and it improves the prognosis of cancer dramatically to quit smoking. It may not be immediate, it may be gradual, but it's a really hard thing to do. So I don't need to just be on my soapbox. We also need to be ready with smoking cessation resources, encouragement. It turns out that people who are successful at quitting, many of them have quit many times. So being, tenacious about it and talking about it. There's good evidence that physicians just mentioning tobacco helps patients realize how important it is. But that's not the only thing. I love the stories that people tell me who've been successful at quitting, how they did it themselves. A fellow whose wife, their whole marriage, she always wanted to go on a cruise, and they finally got to the point where they could do this. And they're in one of the evening sessions and having fun and enjoying themselves. And of course, they've got a hypnotist there, and he brings the fellow up on stage and makes him quack like a duck, and then makes him quit smoking. And he never touched another cigarette. And there's research behind hypnosis and tobacco cessation. So if that helped him to do that, again, I don't need to understand it to know that his health is better because he quit. Family support, there's a lot of things. Nicotine replacement can be important. The New York State Quit Line and other formal smoking cessation programs, lots that can be done to help. I think there's something about the way the person thinks about it. People tell me all the time, I tried to quit 10 times and I went back, or I never really was successful, and something changed in my mind. I knew it was time, and then I just got rid of it. I did it cold turkey, or I got onto medications that helped to make the cravings less, and I was successful. So there is something about that, and where that comes from, I'm not entirely sure. I think it comes from family support. I think it comes from people wanting the best for their health. I hope that it comes from healthcare providers being really, really pushy about that, because it is by far the biggest factor in terms of reduced risk and improved health for many, many people who face and struggle with tobacco addiction. So that's a big one on that list. Other things that people can do, we mentioned exercise, which is always good to plug. General care for the area receiving treatment, skin care, mouth care, monitoring, paying close attention really makes a difference. Radiation causes inflammation, and just doing something as simple as rinsing the mouth and throat with baking soda and salt water, but doing it very, very frequently, constantly through the course of the day, helps to correct the acidity that develops when people develop dry mouth and saliva gland dysfunction. So it doesn't necessarily eliminate the problem, but it can make the severity of symptoms a lot less and help people deal with it. Likewise, radiation causes irritation of the skin. There's a lot of good skincare products that can help them to manage that and to deal with that. Nutrition and hydration are huge, making sure that the person has enough nutrition so the tissues in their body can do the work of healing and recovery. And in head and neck cancer, that is a huge challenge. We cause side effects that interfere with nutrition. Sometimes cancer itself can interfere with nutrition, speech and swallowing and all of these things. And so finding the right strategies to try to maintain that, whether it's oral, whether it's side effect management, whether it's feeding tubes, that can be really, really critical for some patients. We also want the best long-term outcome. So continuing with therapy and rehab, right? Swallowing therapy, speech and language are all things. And communicate. I think that's the other thing during treatment that I encourage. Cancer sucks. People love to say that. It's true. People sometimes go inside. Not everyone feels comfortable to bring their most personal challenges to people they don't know very well in the hospital. People are running around. You meet a lot of different doctors. And some people will tell me, yeah, I think I'm doing okay. I'm doing fine. And they'll tell me months and years later, you know, I had a lot of questions that now I want to know the answer to. Now that I'm through this and I'm looking back, I have some open space. Can we just go backwards? Because I don't really remember a lot of that. I was in shock when I had the diagnosis and I said, let's just do it, whatever it is. I encourage people to, if you can, take a couple deep breaths. And if there's a hard question on your mind, find someone who will talk to you about it. We may not have the answer. The hardest questions I get asked, I don't actually have the answer. They often have to do with prognosis and what's going to happen or how things are going to work out. But I can at least give the person a sense of what that is. I've had people who believed that they had a fatal cancer who had a pretty good prognosis, and sadly the opposite. I've had people who had a cancer problem that was very unlikely to improve, and they didn't really know that. So having good information, and it's our job, it's medical professionals' job to present that information. But if someone lets me know that that information is important to them, whatever it is, the impact on their family, the impact on their social life, their quality of life, whatever the questions and concerns are, our medical system is not always set up to deal with long conversations and providing information. But for diseases as serious as cancer, I think it's a really critical part of what we do.
Right. I always tell people, like, when you're going for your, even most visits, I think, bring somebody with you, especially when you're first getting diagnosed. So that way you have somebody else that's in the room. Because the first thing I was thinking is, oh, great, I'm going to die. I wasn't hearing anything else that was being said to me. My wife, on the other hand, what I didn't hear. So I always tell people that and write it down. You know what I mean? So that way you can remember to ask the doctor when you get there or whatever. You know?
Yeah, that is very good advice. And go back too.
Yeah. And don't be afraid to ask the questions. I mean, you guys have had even most insane questions, and there is no stupid question when it comes to life. So ask whatever, you know.
Absolutely.
I know there's a couple times I've asked questions, and I'm like, why did I even ask that? And at least that over. So. Okay, can you dumb down the 4 R's in radiation therapy, the repair, redistribution, or whatever, I can't even speak today. Repopulation and reoxygenation. There we go.
A little bit.
Yeah.
You're getting into the real science that underlies what we do. So when we treat a tumor, let's think of one that the radiation is going to get rid of. It's going to kill off this tumor completely, and that tumor is going to be gone from their body. And the next tumor is the same, and I'm going to give the same treatment, but it's not going to go away. It's going to persist despite radiation therapy. So those 4 R's are essentially the things that make cancer susceptible or not susceptible. We talked about repair. DNA damage repair in normal healthy tissues can help to protect normal tissues. And some cancers have mutations that make them more or less susceptible to therapies, chemotherapy and radiation. So repair refers to DNA damage repair. repopulation. So when we treat cancers, we found that their growth rate is not even. It's not the same all the time. It seems that timing matters. So for example, giving the same dose of radiation for some cancers in a shorter period of time has a better success rate, probably in part because it's treating the cancer to full dose before the cancer cells really get into a rapid growth phase that might happen with a longer course of treatment. Reoxygenation. So it turns out that many tumors are really poorly organized. The tissues are actively dying. We say necrotic, but that means that the cells are dying often because the tumors are growing so quickly. And tumor cells that are in this abnormal environment, it can be very acidic, there's no oxygen around. This is not where normal healthy tissues live, but for whatever reason, it can make those cells less susceptible to oxygen. So if we can get better oxygenation, we can get hopefully better control of tumors. Redistribution is going to be the little bit complicated one. So there's a cycle of how cells divide. They go through cell division, and it's not one step, and it's predictable. Many cells go through the same cycle, and different cell cycle phases are different susceptibility-wise in terms of radiation. So if all the cells were in the same cycle, if I had a tumor with 1 million cells and they were all in the sensitive cycle and I could hit them just at that moment, maybe I could get them to all die off at once, but they're not. They're all in different cycles. So I need to hit cells in sensitive phases for all of those cells. I need to kill off every last cancer cell to get a tumor to go away. So part of the reason why we're spreading out the dose to many, many small treatments is because we believe that that will give us the best chance of hitting cells in all these different growth phases. And a lot of it we say is empirical. It's because these are the regimens that have proven safest and most effective over time. One of the things that is interesting in that area is that even compared to when I came into this field, we were often very specific about small dose per treatment and many, many treatments to protect normal tissues and reduce side effects. And we found because we can target more directly, sometimes we want to give a very, very high dose. And for many diseases, because we're mapping radiation hopefully more accurately and understanding how it behaves, we can at least shorten the course of treatment some by giving slightly higher dose per day. Some of those regimens are not necessarily more effective, but hopefully they're easier for patients. And in some cases, probably we do have more effective regimens by giving the same amount of radiation over a shorter period of time. There are treatments referred to as stereotactic high-dose treatments or stereotactic body radiation therapy. Again, the acronym and the jargons gets kind of deep, but what it means is very, very focused radiation therapy delivered in fewer sessions, maybe 5 or fewer, and a high-dose treatment. And I've had patients with recurrent head and neck cancers who've had prior radiation who really couldn't safely go through another full course of treatment because of risks of reirradiation, where we were able to give some benefit with very focused high-dose treatments. And sometimes patients tolerate them well. Giving 2 courses of radiation can be risky and the side effects are difficult, but cancer can be the kind of problem that puts people between a rock and a hard place. So we always try to come up with options. And so I think that those 4 R's are often associated with our most conventional long courses of treatment. And I think we're also now trying to understand, again, maybe with technology, that those aren't the only things going on there. Maybe high dose per treatment in some circumstance is going to be safe and effective, particularly in early stage lung cancer, for example. So yeah, good science. And you might edit that part out because that's deep.
Yeah, well, everything I looked into this week kept mentioning the 4 R's. So I was like, you know what, this is bringing up.
Thank you. Yeah, that's the classic.
Okay, so now that my brainiac part is over, let's talk about the actual machine, the inner accelerator. Unlike the MRI, you don't go inside, it rotates around you. Can you just explain, I'm not the actual mechanics of how it works, because now I'm asking you to get into the vision and all that, but just how the machine works for somebody that's never seen it, that's about to go through.
Yeah, and there are a lot of different treatment machines, and I do get a lot of questions about technology. I think we're all kind of raised to recognize there's a difference between a Porsche and a Chevy. Nothing against Chevy, but they're not the same thing. If you're getting cancer treatment, it's just logical that you want the best technology. It turns out there are a lot of different machines that can deliver accurate radiation. We need a way to sculpt the dose. We need a way to deliver it very, very specifically and map it within the body. We need imaging to make sure the patient's in the right place when they receive treatment. We need radiation safety. Different machines use different strategies to accomplish this. The treatment machine that's probably most commonly used, and the one that I'm most familiar with, and the one I use in my clinic, is a linear accelerator. It basically takes electrons, electricity, and it brings them to a very, very high energy level, and then it smashes them into a little bit of tungsten, and it creates X-rays at that given level. And the complexity of the machine is essentially giving us the ability to shape the dose. If you think of traffic in a road, if there's a two-way road, all the traffic has to go right through that. So if I have a tumor in the middle and I'm treating from two directions, everything in between gets all the traffic, it gets all of the dose. There are circumstances where that's reasonable, and those are good treatments for simple things, but many tumors are of irregular shapes and or near healthy parts of the body where it really is helpful to sculpt the dose. And many machines accomplish that by treating from different angles with radiation therapy. So commonly we use arc therapy, where the machine actually rotates around the patient and it's changing the amount of radiation based on the angle, based on what tissues are being touched and the intensity. And it basically has software that's mapping out how we're supposed to deposit the dose of radiation based on all of those scans and all that diagnostic workup. So basically the patient comes into the treatment room. The variety of machines is kind of broad. Patients do slide in and out of some of them. Many of them, the patient stays still and the machine moves around the patient. There's a group of therapists. These are trained medical professionals who give these treatments daily. There's a physician overseeing the process. One really critical thing that people don't always think about is physics, quality assurance, making sure that machine is doing exactly what we think requires daily, weekly, monthly, ongoing, annual quality assurance. And it's overseen by PhD physicists whose entire role is really on the technical side. And it's a really critical part of what we do to make radiation therapy as safe and effective as possible. We also have a lot of support from the vendors, the folks who design these machines, the companies that sell them and market them. We have ongoing engineers who come in all the time to do maintenance and to make sure this is running just perfectly. And complicated technology behaves like complicated technology sometimes, meaning it doesn't always do what we want, and we want to make sure that those variances are as unlikely as possible to have an impact on our patient's health. There is a real risk that radiation is not delivered as intended in our field. It's explicit. We talk about it all day long. We take a lot of images to make sure it's proper. There are a lot of measurements. Patients' charts are checked by myself and physicists on regular basis during their treatment. The machine checks itself. In many ways, it's similar to our cars, where on the dashboard, there's a lot of different lights and signals that can come on if there's a problem. And it's different from cars because our treatment machine is designed so that anything that doesn't line up properly, it just doesn't want to treat. It just stops and it says, get everything lined up the way it's supposed to be, or we're going to take a pause. And sometimes that interrupts treatments, and sometimes it leads to inconveniences. But really, those interlocks are a big part of safety. So there's a lot that is done in terms of radiation safety and how our treatments are delivered to try to make it as safe and effective as possible. And it's not perfect. There are some risks there, and there are examples, including devastating ones, of patients who've had a negative impact from treatments where, for one reason or another, and these have been studied so that everyone in the field can learn from those mistakes and those errors to try to make it more safe. But those are real things that we worry about and deal with in real time. Unfortunately, that's a big part of the improvements in technology that I see. It's not actually making the radiation treatment better as a cancer treatment, but if we can make it safer for patients and reduce the risk of radiation being administered in a way that's not intended, those are just as important as ways to make the treatment more effective for cancer.
Okay, so now that we're on this machine, it's a particle accelerator, pretty much. What is the chances of it actually getting a leak and some kind of other molecule getting in the way? Like, is it powerful enough to actually explode?
Yeah, so I don't believe, and probably a medical physicist could probably correct me on some of this. I don't believe that there's very much likelihood of combustion, of an explosion. What does happen is referred to as scatter. The radiation comes out of the machine, and those X-rays, they hit everything, including air molecules. And there's so much energy level there that it does spread. It's mostly statistically directed where we aim it. And a lot of our technology is intended to aim it where it's going to do the most good as a cancer treatment. But it turns out that our whole room does fill with radiation when the machine turns on. It's a small fraction, but the room, the treatment vault in our jargon, is built in such a way that it protects staff and the hospital from radiation getting out. So that scatter is basically, I think what you're talking about is when radiation interacts with molecules, it scatters within patients, and often that's something that people are aware of. For example, they ask me, could I have a thyroid shield? When I go to the dentist and I get my x-rays, they put a shield over my neck to protect the thyroid because the thyroid gland is very, very sensitive to radiation. It turns out that that shielding is pretty effective for low energy x-rays. They're coming in a specific direction and they're low enough energy that a relatively modest amount of a high density material like lead can protect. Radiation therapy causes scatter that's three-dimensional. So it's, if you were to put a shield here, the scatter touching the thyroid is not all coming here, and it's also at a much higher energy level that shield wouldn't really do what we want in terms of radiation protection. So the way that we protect patients is really within the treatment machine. It's how we map the radiation dose, but there is a small amount that is more broad than what we can see. Fortunately, that is not where the majority of side effects and risks come from. The majority of risk comes from where we intentionally direct significant amounts of radiation to treat the cancer. And that's kind of unavoidable. If we're going to use radiation, we're going to be delivering that inside of living, breathing people. And at some degree, we're going to be touching the normal healthy parts of their body. But as technology gets better, again, better sculpted and more ability to spare is why we see improvement in terms of side effects. So hopefully no explosions. You know, all machines are like that. We like it boring at work. You know what I mean?
Right. I do. I wasn't going to bring that up because I didn't want to scare anybody, but I thought it was just a funny thing. Like, well, it's
Yeah.
so. Okay, so with you mentioning that the entire room gets illuminated with radiation, say somebody was trying to become one of the technicians of minister, is like, can they work like 30 years and doing that and not have to worry about anything? Or is there like huge steps that they got to follow other than just closing the door, you know?
Yeah,
So a lot of people don't realize this. When they see the X-ray technician and they run behind the wall, they're all like, "Oh, it's so safe." It's like, yeah, well, you're only getting one X-ray. This guy's doing like 20 today, you know, on his shift. So that would accumulate.
medical radiation exposure is a known safety concern. There's a lot of ways that radiation is used, isotopes and sources, diagnostic x-rays, therapy, and there are strategies that have been developed to try to improve radiation protection and keep people safe. We also wear monitors. We wear what's called a film badge. So every so often that goes to a company that actually measures out what the exposure was. If that's on my body and that didn't get exposed, that's telling me that I haven't been exposed, hopefully. Radiation is tough because you can't see it and feel it in real time. And so there are some safety issues. It turns out that for external beam radiation therapy, which is the most common treatment, and it's the majority of how I give radiation therapy, as long as it's done very carefully, those risks are pretty low. No one is in the room with the patient when the radiation machine turns on. We don't use, for these treatments, isotopes that directly expose. In my training, and lots of radiation doctors do procedures referred to as brachytherapy. And there are situations where you use hot sources and isotopes, and these can be placed through various implant procedures within areas of cancer treatment. And it's very focused. It's a very good treatment for certain circumstances. There are ways to make that safer. We talk about time, distance, and shielding. So the further away you are from a radiation source, the less time you're exposed, and the better you're shielded by materials that protect from radiation, the less likely you are to have an exposure that poses medical risk. Like we talked about before, we're all exposed to radiation all the time. So some radiation exposure probably doesn't increase risk very much. There are limits that are published. You can look and see what the level of radiation that's appropriate. There are circumstances where people get a vacation they weren't planned. If they're, for example, in the cardiology catheterization lab, they use a technique called fluoroscopy to look in real time. They're looking at an image of where their instruments are within the blood vessels, for example, within the heart, because someone's having a heart attack, and the cardiologist is there and they're adjusting the needle position. And they need a picture to know that it's going to the right place to drop a stent. And so some of those interventional procedures, whether it's radiology or cardiology, can lead to real exposure. And exposure risk is related to time. And so if you have a very small risk and it's managed, probably it's not very likely to impact people's health. And in 2021, I think that most of us who work around radiation and understand radiation safety believe that those risks can be managed when they're at a low level. But yes, we want to protect patients and we want to protect ourselves. And again, there are examples where you may have to stop doing a procedure. A doctor has to go away for a period of time because they've received enough exposure for their limit for that period of time. And we don't want people's health to be jeopardized. So radiation safety is fortunately a big part of what we do. And hopefully it is, again, on the boring list. We don't want that part to be exciting. It does come into play specifically, especially in and around pregnancy. Some of these procedures where a little bit of medical radiation might be appropriate for staff, well, the limits, obviously, for good reason, are much, much, much lower for pregnant people. So around pregnancy, we try to move around people's jobs and just make sure that they are as safe as possible. In our area, in radiation therapy, I think I've seen a lot of progress. There's a main exposure comes from these radioactive sources and brachytherapy procedures. And these days, many of those are done with basically a robot, a high dose rate applicator. The team delivering treatment goes in the room and sets the patient up and attaches the source, and then they step out, and through catheters, through a tube, a radiation source is placed into an applicator within the person's body. And that is one good way to be able to do these important internal radiation procedures, but also no person has to physically place that source where it needs to go because we have a robot. There are still some procedures that are done with hot sources, and fortunately we use ones that don't have a lot of output in terms of time. So you would have to stand there with that source for quite a while before it would give you enough radiation. Another area where the history of our field is unfortunately dramatic. Many of the pioneers and researchers in this field were exposed to much more radiation than would be healthy, and had consequences that in some cases took their lives because really there wasn't an understanding of what that is. So that's a really important question for our field.
Yeah, everybody that was involved in the discovery of radiation died of radiation. So
yeah, unfortunately.
Yeah. I mean, the first guy to discover X-rays, his whole body lit up on the wall. That had to have been freaky. Like, okay, so my final question here is, where do you see radiation going in the future? And do you think there'll ever be a time where radiation won't be needed?
Yeah, that's a really great question. And I think that one danger in oncology, because technology changes, because we see advances in terms of drug therapy, immune treatments that we talked about earlier, for example, there are a lot of really good oncology scientists and cancer doctors who have predicted that we would have better treatments, perfect treatments in the past, even the distant past. There are textbooks that in the 60s suggested that we'd figure out a few things and cancer would be a disease of the past. So there's a danger of overstating our progress. Cancers are really difficult diseases to treat. They change, they become resistant to therapies. They have characteristics where they can essentially, not consciously, but they seem to learn. When we develop a new therapy, those cells become resistant. We talk about selection. If there's a group of cancer cells and I can kill 99.99999% of them, and I leave that very small amount of cells behind because they're resistant, the tumor that grows back is going to have that resistance mechanism. So what do I see in radiation specifically? I think that in a lot of ways, I think there's one pathway where we're going to continue to refine what we do and what we do now and what we know works well for cancer. There are probably other treatments that hopefully, I'll be an optimist and I'll say that hopefully radiation can be at least reduced dramatically, and it would be fine to have it eliminated. I can find something else to do, I'm sure, if we can take care of cancer with smart drugs that don't cause the kind of side effects and risks that radiation has. Unfortunately, I think that that's probably a long process. I do see some really exciting flickers in terms of research, and these are things that are likely years and years away from becoming standard cancer treatments. People are experimenting with the dose rate of radiation. So not the amount of radiation, but how quickly the exposure happens. We want that therapeutic ratio. We want to kill the cancer and leave normal tissues aside. And there's some really interesting ongoing research showing that not just the amount of radiation, but how long the exposure takes seems to impact cancer much more than normal healthy tissues. So if you can give a dose very rapidly, instantaneously, and again, this is very, very much basic science. It's happening in cell cultures and in petri dishes as opposed to in human beings. A lot of things don't pan out that work perfectly well in the lab when we try to use them in living, breathing human beings facing cancer. So again, that might be a long-term one, but using radiation in a way that is quite different, where maybe a very modest amount of radiation is given and causes inflammation that can allow a cancer to be more susceptible to a targeted drug. That would be a really attractive improvement as opposed to having to try to give just radiation by itself to kill off the cancer in its entirety, where I need to give more treatment. I do see the drug development around oncology changing in real time. We've always said that to patients, even if you need more treatment, probably in 2 or 3 years, there's going to be more available. And that's true in the history of cancer. There's been a lot of drug research and improvement. But for the first many years of my career, I saw a lot of diseases, a lot of cancers being treated by the same drugs over and over and over, because they were the most proven and effective mechanism. And I saw a lot of drugs that went through clinical trials that unfortunately didn't seem better than what we had, or their side effects were more difficult. And so we've had drugs that we've used with radiation as sensitizers, for example, where we're still using a drug that was tested in clinical trials long, long, long ago. Some of those are still standard now and save lives. These are not bad things, but I'm seeing more new drugs hitting the market and hitting approval from FDA and helping patients live longer with difficult cancers. Melanoma is a good example. It's a very terrible skin cancer that in many people can spread and be very resistant to treatments. And I saw a lot of young people with melanoma with very few good treatment options. And we now do have immune-related therapies and targeted drugs that at least give those people more hope and more treatment options. They're not perfect. Resistance develops, and cancer problems still are just really many of the hardest problems we face in medical research. But I do think that that progress is something that's going to continue. And there's a few diseases where many of us are just dying to see a home run. Bad aggressive brain tumors is a good example. There are diseases where when that diagnosis is made, for most patients, these are going to be rapidly difficult to manage despite best treatment, even with every resource. And we've seen that in famous people who've developed aggressive brain tumors. We know and understand that there's no lack of resources that people in that position have to get the best care there is. These are just diseases that resistant to treatment. And I don't think it's wrong to be optimistic that we're going to see drugs that can really change that landscape. And yes, I probably do think that there's the potential that radiation will become less. Unfortunately, I probably think that these diseases are varied enough. There's enough different types of cancer that in many ways we're going to need to continue to fine tune how we target with radiation, what the amounts are, how to spare normal tissues, and how to protect better, because I think we're going to be using these treatments in a lot of the ways that we do over the near future, the next 10 and 20 and 30 years.
I'm definitely intrigued to see where it goes. I mean, in the last 100 years, we've come so far, so it's going to be intriguing to see where it goes from here. Okay, doctor, I am so glad you came on the show. Thank you for taking the time out today.
Yeah, thanks so much for having me. I appreciate it. You really do an amazing job of bringing advocacy and bringing a positive message to a situation that needs to be illuminated. People need to see and understand dealing with head and neck cancer, and specifically dealing with laryngectomy. Going through surgeries like that is a hard thing. It's something that nobody wants to hear. And I see a lot of people recovering well and having a good quality of life, despite having to go through a surgery that they would prefer not to have had. But I haven't seen a lot of people bring the positive energy and the advocacy and your willingness, even when you were in the midst of this, to really be loud about making it your job, not our job, not everyone's, your personal job to make the best for this situation. And I appreciate the help that you give to patients who are looking at this from the front and are scared and are looking for good quality information. I really appreciate the fact that you do your homework and you know what you're talking about, and you present people with good quality information in a setting that's easy and accessible. And I appreciate being here with you. Thank you, Henry.
I appreciate that. That's amazing. Thank you. So that's all we got for this week. And I guess sayonara. Well, if you made it this far, I'd like to thank you and hit that like and subscribe button, because you're obviously a fan. I do like to apologize to Dr. Powell on two things, okay? One, my sound being all messed up because, don't know how to push a button. And two, I didn't really, I suck at that getting compliments. I'm really bad at them, and I really appreciated the compliment that he gave at the end of it. It was very humbling, and the way I reacted to it was just it was like I blew it off, and I didn't. That was a very nice and humbling thing that he said for me. So on that note, guys, this is the end of the episode. Don't forget to check us out on Larry World, the little Facebook group I created. Post some memes if you want, get it interactive, talk about the show. Also check us out on Facebook page, Lary Talk, and you can check us out online on larytalk.com. Remember, we have a help and support section there. So if you're looking for help and support in your area or online, please contact our help and support area and find help that you need, whether it be insurance, whether it be transportation to and from appointments, anything like that. You can find it on larytalk.com. Also, give a shout out to Aaron Wayne, of course, as always. Check out his book. He had mentioned something about writing a second one, so I look forward to see what that's about. Thank you, Dr. Powell, for the interview, and thank you guys for your support. Until next time, take care of yourself and have a good one.